Right. I think we're ready to kick off, Dr. Reid.
Awesome. Well, it looks like we're live. Welcome everybody. We appreciate your guys' interest in joining one of the ASRM Journal Clubs. We're joined today by Harvey Chim and one of the senior authors on his paper that he put out recently looking at tranexamic acid and free flap breast reconstruction, which you'll have a link to that article shared as a piece of this. Our hope is that we're able to stir some lively discussion and get a little more insight into how these guys came up with this paper. And maybe as a way of introductions, I'll sort of introduce myself for those of you that might not know, and then we'll just go on down the line so we can get an idea of who's here. My name's Chris Reid. I'm one of the faculty in San Diego, and I am a active ASRM member, and I do a fair amount of microsurgery. I'm very interested in this topic. I was actually texting with Baris earlier because I have a similar paper on it that actually just came out today, which is sort of ironic. A lot of different groups are interested in this sort of new role for tranexamic acid and how it interplays into things that we do. So we picked it, thought it would be a good idea, and so that's me. If you guys want to introduce yourselves.
Yeah, thank you so much. So I'm Harvey Chim. I'm a plastic surgeon at Louisiana State University in New Orleans. I do a lot of microsurgery in my practice as well. The vast majority of the microsurgery that I perform is extremity microsurgery for the upper and lower extremity, as well as peripheral nerve and brachial plexus. And I used to do breast and more breast and even some genders microsurgery, but I stopped doing that a number of years ago. And I still occasionally do some head and neck microsurgery. So I'm very happy to be here on this interview. Thank you so much for having me. And also, I'd like Ramin, our first author of this paper, to introduce himself.
Oh, absolutely. So my name is Ramin. I'm a research fellow at LSU. I'll be joining residency at LSU this July.
Congratulations.
Thank you so much. And yeah, I've been working with Dr. Chen for almost 4 years now, and I'm very excited to be here.
That's great.
Wonderful. And last but not least, I'm Baris. I'm one of the plastic surgery residents, currently in third year, interested in microsurgery, and I'm a member of ASRM as well. Excited to be doing this with Dr. Reid, so we can get to learn more about what's all about with TXA and breast free flaps.
Great. Well, it's very fitting that this, microsurgery paper comes out of kind of the cradle of breast microsurgery down there in New Orleans. Is really iconic for that. And maybe, the first question I would want to pose, or we can just dive in to talk about is, can you guys maybe elucidate like how this concept came up or why you got interested in wanting to investigate this area?
Well, I love Ramin to weigh in on this as well, but I really think that for me, it's such an area of focus in microsurgery, as you mentioned, right? It's really one of the new and exciting things that people are using in free flap reconstruction. I'll say that in my practice and in New Orleans in general, nobody was using and nobody is still using it, because I think in some ways the breast surgeons here in the city are so technically skilled and, they're able to get the flaps done so quickly. So they don't think about adopting new things like TXA into their practice. So we thought it would be an interesting question to address in the paper. Do you have anything to add, Ramin?
No, nothing. Nothing to add, Dr. John.
It is.
I think that there has been a lot of publications on as well recently on the role of TXA for free flap reconstruction, and the results have been, a lot of them have been kind of contrary to, some say it's completely as effective for treating, for like reducing the risk of intraocular bleeding and hematoma, and or some studies have shown that there are no effects in that. And like we wanted to explore a larger number of patients who've been underwent through this procedure using TXA and see what happens.
Cool. It definitely has become very vogue. It was, gosh, maybe 6 or 7 years ago, I was presenting at a facial plastic surgery meeting, actually, when I kind of first started to hear about people using it widely, and they were talking about doing it topically on their facelifts. And it was right around that time, me and a couple of my partners here, we started using it for all sorts of stuff, putting it tumescent, using it topically, and it sort of, that all, I feel like, happened all over the country. We were all sort of doing this in all these different ways because lots of specialties were. And many people have used it for years, orthopedic surgeons, particularly spine and joints and trauma. And there is like a bounty of literature in other areas. And I echo what you said, Ramin, that like there's been a big sort of deluge of these papers in plastic surgery in general, which you guys do a great job reviewing. And I think for any of the audience, it's a really good opportunity to see that stuff in the paper because it gives you some of those links. But also in microsurgery, I'll just tell you anecdotally, I had a breast surgeon telling her about this, and she was using it a bunch topically, which, for cut to the chase, doesn't actually do anything. And I tell her that all the time. She still uses it. But, I wanted to think about doing it during microsurgery cases, and I reached, some friends around the country, and, it was just funny because they were so scared. Like, no way. Like, how dare we? Like, we can't let that happen. And, I'm a big myth buster and kind of worrying about the things that we do in microsurgery. I think there's just a lot of like non-evidence-based practice. So it's excellent, really cool to have a paper like this come out and people get interested in what prompted us to look into it. And Scott Hollenbeck and his team have also have a good paper that's going to come out probably this year. It actually won the Southeastern Society's award for one of the best papers. So, I think definitely an area of interest that we're all hot on. If I could maybe get you guys to break down and describe the methodology and how you went about answering this question, and specifically maybe for those that aren't familiar, kind of explain to us what the Trinetics database is and why you thought that was a good option to answer this question.
So I think Ramin should tackle this one.
Absolutely. So we were wondering how can we get access to a large amount of patients who had free flap reconstruction and received TXA during the surgery and compare it to people who actually didn't receive it. So we figured out that the best way that we can do it is to kind of use Trinetics database. Trinetics is like a national database. A lot of institutions have access to Trinetics. It's a very large patient population, and you kind of can make your own cohort and like be very specific about what kind of cohort you want to be including in your study. So that's one of the pros of using Trinetics. The main problem with using Trinetics actually is that the outcome measures are very, very limited. And most often the patients, like it's maybe because the way that was recorded, but you cannot have a lot of outcome measures. So that's one of the limitations of using this database. So we decided to use Trinetics. We included two cohorts, patients who received TXA and patients who haven't received that. And we did a propensity-matched analysis. So both groups were similar relatively in terms of preoperative baseline demographics, such as like age, previous comorbidities, and so that we can kind of like evaluate our outcomes by reducing a little bit of like these like confounding factors that can be affect the postoperative outcomes.
That's really exciting. I think that's one of the powers of these kind of large database studies, that you have access to a lot of patient data, for example, 20,000 patients in this cohort, that you can optimize it for your analysis. Can you tell us a bit about how you kind of can seek through these outcomes and how they are kind of recorded in this database for analysis?
The majority of the outcomes are based on ICD-10 codes or CPT codes. So you just gotta, for example, if you want to see surgical site infection, you gotta look for all the ICD-10, all the CPT codes that are associated with this, and kind of make a group. And the group of these codes are going to be, representing the number of events of your outcomes. That's mostly how you kind of like look at the outcomes in Trinetics.
And we did a couple studies on that database, and I think it's very powerful. It's also, correct me if I'm wrong, it's pretty convenient. meaning, like the interface is really easy to use and it allows you to sort of make these matched groups. And I think it's a really good uh, product that is come around in health sciences research to allow us to answer these big data questions, because I think some of the other things that we've used in the past, like NISQUIP, NIS, and other things, they have real significant limitations. So Tranex, it does have some great functionality and I think opportunities, particularly for answering big questions like this.
Yeah, I think databases have really become database studies have become really popular recently. So certainly TriNetX, Pearl Diver, Epic Cosmos. I think we see so many studies of those that are published in all our journals. But I think the key really is still to pick a relevant question, because I think we've all seen good and bad database studies, and it doesn't necessarily come down to the numbers, but the question that's being asked. So if there's a question that asks with not really a clinical relevance, or where the answer is already known, then it's less useful. So, I think we are also guilty of producing a lot of database studies, as you probably are, because it's just so easy to do. But ultimately, again, it comes down to the question and whether it has a clinical relevance that can be applied to the
I
findings of the study.
I couldn't agree with you more. And I think, maybe as advice to the, junior surgeons and people getting interested in pursuing surgeries, you can finesse a database to say anything you want, or
Yeah.
run enough analyses with enough iterations to find something that is different or statistically significant. And I really think people need to exercise a lot of scrutiny and caution, and begin with a really good question, come up with a reason and a why. And I really think those are the interesting things, like stuff that catches people's attention or that we really don't know. Pursue that rather than just start kind of throwing stuff at the wall. Because if I had a nickel for all of the medical students who have proposed some random thing and they're going to do it, and I'm like, well, like, why are we going to do this? It's just flooding the literature. But you guys maybe want to kind of walk us through what you found, and in sort of in your own words as the authors, what you think the audience should take away from the paper, or that how you would explain this to maybe like mom and dad.
So I think Ramin should start with this first.
Absolutely. So we included approximately 21,000 patients, and after propensity score matching, we had about 524 patients in each group. And then we compared outcomes between the two groups. And we found that we found two important and kind of contrary to prior report findings. The first one was that the rate of hematoma formation was significantly higher in the TXA group, which was kind of surprising. But the rate of intraoperative hemorrhage occurred like in the non-TXA group. Like we did not have had any kind of events in the TXA group that had intraoperative hemorrhage. Other outcome measures such as seroma formation was also kind of more frequently occurred in patients that received TXA. But other outcomes like flap loss, postoperative bleeding, the rate of thrombosis, they were relatively similar between the two groups.
So I think for me, I have not jumped on the TXA bandwagon. And in my practice, really, I don't think hemorrhage has really been an issue with free flaps. We're all more concerned with thrombosis and the flap going down. And I personally haven't thought much about bleeding as a problem in free flaps. So this study, makes me a bit more hesitant to jump on the TXA bandwagon and use it for all my patients. So I think for me, that would be the clinical implication of this study. And again, as mentioned, I don't think anybody in New Orleans who does a lot of microsurgery uses it routinely for free flap reconstruction.
I think that is a great takeaway. And I have a paper that's coming out right now on the topic, and I'll tell you, essentially the takeaway from that one is that we did a bunch of cases, my own cases, and we didn't lose any flaps. And
Yeah.
that's the takeaway, was that it was safe, right? That it didn't cause thrombosis. And I think, Harvey, you make a really good point that when I had talked to my friends about that, or I was trying to recruit other friends of mine to maybe be a part of it to make it a bigger deal. One of the greatest criticisms was like, well, I mean, are you having a lot of hematomas during breast microsurgery, which is primarily what I do. And I agree. I think that extends to extremity reconstruction in other areas. And it kind of don't. I think
Yeah.
there are certain procedures in plastic surgery, like some of the big soft tissue work, maybe if you're doing like abdominal wall or breast reductions, maybe, but it does beg the question of, especially with the data you guys show, like why? If your hematoma rate isn't that high to begin with, like why even worry about it? We did it purely just to try to debunk the myth. I wasn't necessarily promoting. I think everyone should use it, but I think there are people out there, and this is really helpful.
On that
Um,
note, Dr. Reid,
yep.
so one of the things I paid attention in the article is the hematoma rates. So we're talking about 15 and 21% hematoma rates in this kind of database cohort study. What are your thoughts on those rates? Do they reflect the hematoma rates that we typically see in other studies, or are they kind of on the high end of things?
Well, I think for me personally, I feel it's on the high end of things. And really, the data that you get in the database depends on the data that's put in by people. So the people who are using TXA are probably a select group of surgeons. And, obviously, what we have is data from the database, and it may be that their hematoma rate is higher than the usual microsurgeon who's not using TXA. But really, this is the limitation of any database study that you use. And the advantage of the database, obviously, is a large number of patients. But again, it's so dependent on the data that goes into the database.
Yeah, but we're unable to know, like do exactly those people, are they having issues with hematomas? Are the times that do they use it all the time? Do they use it uh in the cases that they have hematomas because they were concerned it was going to happen? You really lose that granularity. That is the downside. Was there anything that you guys found and that you kind of worried about maybe not reflecting the accurate depiction of the real world, or like what cautions would you give as people read your paper to just make sure that they don't make the wrong assumption or takeaway?
So I think there are a lot of limitations inherent to database studies, and maybe Ramin can give us a bit more of a rundown of this.
Absolutely. So I think, yes, as Dr. Chen mentioned, the main problem with like the main issue, like the readers have to be very cautious when like interpreting our data, is that you are looking at um, a database study. It's not a randomized controlled trial where you can control for everything. Like it's going to be a single surgeon experience. There are a lot of rules in there that's like different between institutions. The rate of the rate that the surgeons report their outcomes, how they report it, how the data was entered into the database, it all has some sort of impact on our study. There is always going to be selection bias. There's always going to be a selection bias in our study. So I think that's the main limitation, is the actual database and the data that was entered into the database.
Yeah, I think that's fair. Um, do you guys have any plans to do anything that's an offshoot from this investigation, or anything that you're going to sort of leapfrog from this?
Not really at this point of time, because obviously if the hypothesis is that TXA reduces the rate of bleeding, then we might consider adopting it clinically. But at least from our database study, it seems to suggest it increases the rate of bleeding. And I mean, the other thing is that, again, we don't really have a problem with bleeding in pre-flaps. So that's why, it's a hard argument for us to start doing a clinical study on TXA.
I think one of the things that's kind of hard to capture in these database studies, which you all kind of highlighted in the article as, is the dosage and the formulation of TXA. Is it, topical use intraoperatively? Is it IV? Is it PO postoperatively? I'm seeing all of these in the literature, and there's just quite a bit of heterogeneity in what is kind of the routine for this. I think big takeaway for this is just, it seems to does not affect any thrombosis related complications, and can be used in microsurgery, but the dosage and how to use it is still, still needs further exploration.
So true.
Yeah, I think that is also, something we could and really should be looking into because, I know at the Children's Hospital, they'll do infusions. Same thing with some of the big ortho surgeries. Um, I can tell you what I do with TXA is they get a gram at the beginning of the case, and then they get a gram like sometime around the time that we're closing, just because it's a longer case. The times that I use it in surgeries, like a breast reduction or other stuff, they just get a gram up front because the surgery is short enough. What I have been told with TXA is that you do have to sort of have it in the bloodstream around 30 to 40 minutes for it to get everywhere and be effective in your surgical site. So it's not great if you um, are giving it mid case because it might not really be able to get to the sort of end organ, which is your wound right away. But I wonder. I haven't given high doses. I think the best we know about the literature is that it's not a problem. It's very rare that the issues that they saw, when they tried to look at those trauma studies, is that like you have to pretty high doses to get an issue. But I do think this is a great impetus for us to look into it more and see because um, it could be having an untoward effects and we're seeing more hematoma, which is contradictory and maybe that someone gets into it and discovers it. I think the strongest thing for me from your guys' paper to want to do that again, I agree with Barsh that like um, I think it proves the point that you're not losing a bunch of flaps. That's not the problem necessarily, but also that it was such a small, like it's a big number, like it's a great number to analyze, but it was such a small number of the overall cases done that this is still like a very boutiquey minority thing that is occurring, that people use it in microsurgery. And so I do think we got to see it unfold a little bit with more people and or the people that are out there that aren't getting captured from the Trinetics database, like actually start to share stuff. So I think we'll kind of see. Uh,
So I have a question for you, Chris. Are you
yep.
using it routinely for a lot of cases like flaps? You mentioned breast reductions as well. Are you using it for everybody routinely?
I basically use it for everybody, um, other than like something silly like a tissue expander to implant case, right? Like I like cases that I expect no bleeding. Like you imagine some upper extremity hand cases, like you would never do it for a carpal tunnel or
Yeah.
something, right? But breast reductions. I tend to do a lot of breast surgery, or big orthopedic oncology cases. All my flaps I do it on. And again, I don't purport to say that it's like so great or that it's not causing hematomas or other things. I personally don't know that it hurts, which is kind of the reason why I do it. It's sort of like it's a 25-cent potential benefit with minimal risk, but will be the first to admit that I don't have any evidence necessarily to stand on for that because it's so mixed. I mean, I think a lot of people are probably surprised by your guys's findings.
Mhm.
And I don't think that makes them invalid in any sense. It's just, I think this is an interesting area, and I think in 5 years we're going to know a bit more about it. And so it's good for you guys because you're in at the ground floor. You have a paper that's going to get cited a bunch of times for sure.
Awesome.
Um, Harvey, as someone who's kind of been in it and has the experience, are there any other uh, kind of voodoos about microsurgery that you can think of that you have an opinion on that you're willing to share that a lot of people do?
Dr.
I,
Reid is
I,
looking for the next myth to be busted.
I have so many voodoos about microsurgery, as I'm sure you have as well. So one of the myths is that you cannot undrape the microscope before the case is done. Do you have that one as well? When the nurse
Yep,
tries to take
yep,
the microscope
yep,
out of the room, you're like, don't undrape the microscope.
yep.
Yeah, so
Yeah.
yeah, I think that's the main one. And then I mean, there's so many skilled microsurgeons in the US. I think what I've learned over the years doing microsurgery is that I feel that a lot of the complications that you encounter post-operatively can be predicted intraoperatively. So you get venous thrombosis and all that, but very often that's due to the lie of the vein or specific to extremity microsurgery. I feel that sometimes it's because of an unrecognized point of compression, like if the vein is kinked or you haven't released the fascia enough proximally. So for me, I feel that a lot of the factors that predispose to venous thrombosis can be predicted intraoperatively and prevented with experience. I think in
I
extremity, yeah, go ahead. Yeah.
I could not agree more. Go ahead,
Yeah.
go ahead. I think it's a follow-up.
No, and then yeah, the other thing I was going to say is what I've learned over time is that at least for me in extremity microsurgery, the main issue more is arterial insufficiency and spasm. Because unlike let's say breast microsurgery or head and neck, you face the problem of spasm in extremity microsurgery, and I found that very hard to overcome. So when I encounter that, I tend to just switch the vessel. I've tried using a Fogarty, I've tried flushing it, and things like that. But if the vessel is not good or in the zone of injury, I think the most important thing for arterial insufficiency is to either go proximal or to switch the vessel. So this is what I've learned over time, sometimes painfully, so that I've changed, what I've in some ways what I've practiced over the years.
Totally. And and I even unpack that a little bit more for the audience too, that when you think about head and neck and breast and why, I mean, especially breast, these like numbers are so good with outcomes, right? I
Yeah.
mean, like you should never really have a deep flap go down for any reason, in my opinion, is that artery's coming off the heart.
Yeah.
Right. I mean, it's just like you almost like can't screw it up because the pressure's so high. And that really is one of the challenges in extremity microsurgery is, the farther away you get from the heart, the less predictability, the less control you have. Obviously, I mean, you guys are doing replants and other things, and God bless you, because those vessels are tiny. But I think that definitely plays a role for sure. You make a really good point too about uh, when issues come up in microsurgery cases, the more cases you get under your belt, you sort of knew it was going to happen, right? You,
Yeah.
you don't. I think it's very rare, and if it happens, it's probably because of the Kruger-Dunning effect and not knowing what you don't know. But if something goes wrong with a flap, you sort of saw it. You saw it down the road. You knew what it was, and you sort of predict it, which is a hard thing for the junior surgeons coming up to understand. One of the best advices I got from Mark Reshnick, who was a hand surgeon in town and really kind of one of the early pioneers of microsurgery, with Randy Sherman, he always was like, listen, he's like, you never leave the operating room unless it's going to work. You got like one shot that first trip, and do whatever you need to do in that first surgery to make it work. Make sure your vessels are appropriately put together the right way with the right geometry, with the right plan. Because as long as you got all that stuff taken care of, you shouldn't really have an indication to ever have to go back to the OR. And if you did it right the first time and you corrected all things, it's not like there's going to be something you could fix the second time to make it better, truthfully.
Yeah.
So
Yeah. I want to add to that as well. So I think if you're a junior surgeon or resident, sometimes you have that gut feeling that something looks a bit strange. And I know that, when I was early in my practice, sometimes I had that gut feeling, but you don't really know what exactly is wrong. So I think it's important to trust that gut feeling. And then like Dr. Reid was saying, if you suspect something is not going well, then you would want to watch the anastomosis, go and get a cup of coffee or do something else. And then if it's still flowing after like 45 minutes, then half an hour, 45 minutes is probably going to be okay, right? What do you think, Chris?
I totally agree. And yeah, I think what it boils down to, maybe as again a takeaway for some of the up and coming people, is all of the other things that often get attributed to the outcomes of these cases is blame assigned to people other than us,
Yeah.
right? Like, oh, it was the patient, oh, this, whatever. And I really firmly believe that every single complication that ever happens is a direct result of surgeon performance. And the sooner you start taking ownership of it, and then you start to understand it because you feel it in your heart that happened because of something you did or you didn't do, then you can be better the next time. And I think that's a really important thing to do, which is, again, maybe to try to tie this back into why we're here, that you know TXA is not going to overcome a really good surgical performance.
Yep.
Like you're going to be able to get flaps to work if you do it the right way. It doesn't matter, you do this, you do that. Who cares about aspirin or whatever? It's all surgical technique, and surgical excellence is the thing that I think everyone should strive for and not get hung up on the voodoo's, which we all share some of them, unfortunately. But I think we've got a good discussion here. I always like when I get to meet a new microsurgeon I don't know well to ask him this question, which is, could you tell us, Harvey, your favorite flap and maybe why?
So my favorite flap now is a thin PAP flap or thin ALT, anything thin. And I think that's really exciting and really one of the new things in microsurgery, at least in the US. It's not new, in other parts of the world, but it's new in the US And again, to clarify what I mean by thin flap is when you raise a flap in the suprascarpa or the subcutaneous fat plane. And that's very important in extremity microsurgery because to get a like-for-like match, very often if you raise the traditional ALT in the subfascial plane or, or even the PAP flap or whatever you choose to use, then the flap tends to be too thick, especially in patients of high BMI. So we routinely do thin flaps or super thin flaps to achieve a nice contour. And, I think that's really exciting in my practice. And the other thing that we do a lot is to use ultrasound for perforator mapping. And I'm sure you do as well, Chris. So I think maybe it's a long answer to your question, but my favorite flap is really to raise a thin flap, like an ALT or PAP or even thoracodorsal artery perforator flap. One of these things that, that's so sexy and so interesting for extremity reconstruction.
That's awesome. Well, any other last comments you guys have to add?
I think that was a wonderful discussion.
Really,
Thank you so much for joining and sharing these thoughts.
Yeah, and thank you for having us. This is really amazing, and thank you for picking our paper.
Of course, we appreciate you guys taking the time and continue the hard work. Look forward to things that we have to come. Reminder to everyone, we got the upcoming meeting next year, which I think is going to be a blast back in Fort Lauderdale. And for those of you on the sort of junior side, don't forget to join the Young Microsurgeons groups and plenty of these other opportunities. So keep your eyes open on social media, and we'll help people get involved in the ASRM group. Have a good weekend, guys.
Yeah, thank you so much.
Yeah.
Everyone.